Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 251 of our pharmacotherapy series, which majors in intraabdominal infections. The first question reads, T.D.S., a 54-year-old man, presents to the hospital with a 1-week history of abdominal pain and tenderness, localized to the right upper quadrant, fever of 38.9 degrees Celsius, and chills. He complains of nausea, with 3 episodes of emesis occurring in the past 24 hours. T.D.S. appears jaundiced and reports dark-colored urine. His laboratory values are the following. White blood cell count of 17 × 10⁻³ per microliter. Serum creatinine of 1.1 mg per deciliter. Total bilirubin of 6 mg per deciliter. Alkaline phosphatase of 270 units per liter. What evidence of cholangitis exists in T.D.S.? How does the presentation of cholecystitis differ from cholangitis? The clinical manifestations of acute cholangitis vary, but the classic presentation involves Charcot's triad, which consists of fever, jaundice, and right upper quadrant abdominal pain. Fever is present in 90% of cases, and jaundice and abdominal pain occur in 60% to 70% of cases. A smaller percentage of patients, generally with gram-negative septicemia, may present with changes in mental status and hypotension. Laboratory findings of acute cholangitis include leukocytosis, elevated bilirubin above 2 mg per deciliter, and alkaline phosphatase, and mildly elevated liver transaminases. The clinical signs and symptoms of cholangitis, as exemplified by T.D.S., include high fevers 38.9 degrees Celsius, chills, jaundice, and right upper quadrant abdominal pain. Laboratory evidence supportive of cholangitis includes leukocytosis with WBC of 17 × 10⁻³ per microliter, increased bilirubin of 6 mg per deciliter, and elevated alkaline phosphatase of 270 units per liter. The clinical presentation of acute cholecystitis involves fever and prolonged constant abdominal pain, typically localized to the right upper quadrant, followed by nausea and vomiting. On physical examination, tenderness in the right upper quadrant and a positive Murphy's sign, that is, inspiration is inhibited by pain on palpation, are often present. Laboratory findings include leukocytosis with increased neutrophils, that is a left shift, and mild elevations in transaminases. Jaundice is less common in patients with cholecystitis, bilirubin less than 4 mg per deciliter compared with cholangitis. Diagnostic imaging for acute cholecystitis and cholangitis involves ultrasonography. Findings for acute cholecystitis may reveal perichoral cystic fluid, distension of the gallbladder, thickening of the gallbladder wall, stones, and a sonographic Murphy's sign. Ultrasound is less sensitive for cholelithiasis, but it may reveal biliary dilation with stones. Hepatobiliary scintigraphy is another diagnostic tool used to identify obstruction of the cystic duct. After intravenous injection with technetium hepatobiliary aminodeacetic acid, abbreviated as TCHIDA, failure to observe gallbladder filling suggests acute cholecystitis. Computed tomography imaging may be superior in determining the extent of biliary obstruction. Endoscopic retrograde cholangiopancreatography, abbreviated as ERCP, is an alternative mode of imaging for cholangitis. The next question reads, what are the most likely organisms causing infection in T.D.S.? What clinical specimens are helpful to identify the causative pathogen or pathogens? The most common pathogens associated with acute cholangitis include Escherichia coli, Klebsiella species, and Enterobacter species. However, Pseudomonas aeruginosa, skin flora, Staphylococcus species, Streptococcus species, and Oropharynx bacteria may be implicated. Anaerobic organisms, commonly Bacteroides species, are associated with approximately 15% of infections, particularly in elderly patients undergoing biliary tract surgery. The etiology of cholecystitis typically involves Escherichia coli, Klebsiella species, and Enterococcus species. Anaerobes are less commonly isolated. As described above, the stasis of bile flow results in proliferation of bacteria within the gallbladder or common bile duct. Acute cholangitis results in increased pressure within the common bile duct with dissemination of bacteria from the biliary tree to the bloodstream. Blood cultures may be positive in up to 40% of patients with symptomatic acute cholangitis. Acute cholecystitis may reveal positive bile cultures in 20% to 75% of patients with symptomatic disease, but the utility of bile cultures has yet to be determined. In contrast to cholangitis, bacteremia is unlikely with cholecystitis. The choice of antibacterial agents is largely empiric, covering the aforementioned common causative pathogens. Regarding treatment, definitive therapy for both cholangitis and cholecystitis must involve source control, using surgery, percutaneous drainage, or endoscopic intervention. Empiric antibacterial therapy should be added owing to the likelihood of secondary infection and to prevent complications. Supportive measures include fluid and electrolyte supplementation and analgesia. To decompress or drain the biliary ductal system in cholangitis, ERCP is used with a success rate of greater than 90% in the treatment of cholangitis. Alternatively, percutaneous transhepatic biliary drainage or endoscopic sphincterotomy can be used to drain the contents. Open surgery is a less favored option to decompress the biliary tree as it is associated with increased mortality. Acute symptomatic cholecystitis requires removal of the gallbladder, also known as cholecystectomy. The procedure of choice is laparoscopic cholecystectomy within 48 to 72 hours of onset of symptoms. Early intervention is associated with decreased morbidity and length of hospital stay compared with delayed surgical intervention. In high-risk patients, in whom the risks outweigh the benefits of early surgery, percutaneous cholecystostomy can be performed to drain the contents of the gallbladder. The procedure improves the clinical symptoms in 75% to 90% of patients who cannot undergo surgery. Cholecystectomy, however, should take place once the patient is stable enough for surgery. The next question reads, based on the most likely causative pathogen or pathogens, what empiric antimicrobial therapy is recommended for T.D.S., given a diagnosis of cholangitis? Empiric antimicrobial therapy for acute cholangitis and cholecystitis should be initiated after blood cultures have been collected. The empiric choice of therapy should cover enteric gram-negative pathogens, particularly Escherichia coli. In general, the addition of anaerobic coverage is not mandatory for cholecystitis, however, it should be considered in the setting of severe cases such as acute cholangitis, biliary enteric anastomosis, or healthcare-associated infections. Empiric coverage for Enterococcus species should be considered for patients at risk for healthcare-associated infections, such as immunocompromised patients, patients who have required long-term hospitalization, patients who have received broad-spectrum antimicrobial therapy, or patients with valvular heart disease or prosthetic intravascular materials. Antimicrobial therapy must be guided by drug pharmacokinetics and pharmacodynamics, local resistance patterns, and patient factors, such as drug allergies, renal or hepatic dysfunction, and cost. Considering their activity versus multidrug-resistant gram-negative bacilli, carbapenems generally should be reserved for infection caused by these pathogens. Vancomycin may be added empirically in healthcare-associated biliary infections in which ampicillin-resistant enterococci and MRSA are of concern. Linezolid or daptomycin may be considered in cases of known vancomycin-resistant Enterococcus species (VRE). Empiric broad-spectrum antimicrobial regimens should be narrowed, when possible, based on culture and susceptibility findings. For mild to moderate community-acquired acute cholecystitis, monotherapy with cefazolin, cefuroxime, or ceftriaxone is recommended. Because of a wide prevalence of ampicillin sulbactam-resistant Escherichia coli, this agent is no longer recommended for empiric use. Resistance to fluoroquinolones is problematic with unpredictable susceptibility of Escherichia coli to ciprofloxacin and levofloxacin. Current guidelines for complicated intra-abdominal infections, abbreviated as CIAI, suggest fluoroquinolones be considered for therapy when institutional antibiograms indicate greater than 90% susceptibility of Escherichia coli. Use of aminoglycosides is not routinely recommended because of the need for therapeutic drug monitoring and potential nephrotoxicity and ototoxicity. Furthermore, in comparison with other regimens, aminoglycoside-based regimens are inferior in the treatment of intra-abdominal infections. However, some argue the decreased efficacy of aminoglycosides has been caused by inadequate dosing. An appropriate empiric regimen for T.D.S. would be piperacillin tazobactam 3.375 grams intravenously IV every 6 hours. The next question reads, the physician caring for T.D.S. questions the need for an antibiotic that concentrates in the bile. Is there a benefit to using an antibiotic that is extensively excreted into bile? Common bile duct obstruction prevents the entry of antibiotics into the bile, and the need for high biliary concentrations of antibiotics in the treatment of cholangitis has been debated. Nagar and Berger concluded that a number of antibiotics with excellent in vitro susceptibility, but poor biliary excretion, are still clinically effective. Biliary antibacterial concentrations do not correlate with an improved clinical outcome. Highly biliary excreted versus moderately biliary excreted antibiotics have been compared. Serum concentrations are more important than biliary levels in reducing the septic complications of biliary tract surgery. Furthermore, biliary excretion of any antibiotic is minimal in the presence of obstruction. The treatment of T.D.S's biliary tract infection must include biliary drainage. Piperacillin tazobactam should be continued for 4 to 7 days. The next question reads, M.O.W., a 51-year-old man with alcoholic cirrhosis and significant abdominal ascites, presents with a 4-day history of fever of 38.4 degrees Celsius and abdominal pain. Ascitic fluid obtained by paracentesis was cloudy, and culture of the ascitic fluid is pending. Laboratory values include ascitic fluid PMN count of 450 per microliter, serum WBC count of 12.2 times 10 power 3 per microliter, and total bilirubin of 4.4 mg per deciliter. So my question to you is, what organisms are likely to be cultured from M.O.W's ascitic fluid? An estimated 70% of cases of SBP are caused by aerobic enteric organisms considered normal flora of the GI tract. Escherichia coli is the most common pathogen, followed by Klebsiella pneumoniae. Other common causes of spontaneous bacterial peritonitis include Streptococcus pneumoniae and other Streptococcus species, accounting for 20% of cases. Enterococcus species are isolated in approximately 5% of cases. Staphylococcus species, anaerobes, and microaerophilic organisms are rarely reported in community-acquired spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis is largely a monomicrobial infection. One of the main mechanisms of pathogenesis associated with the development of spontaneous bacterial peritonitis is bacterial translocation, which is the migration of microorganisms through the GI wall to mesenteric lymph nodes and other structures outside the intestine, including the bloodstream. Bacteria then infect the ascitic fluid by hematogenous or lymphogenous spread. Certain characteristics of cirrhotic patients facilitate the pathogenesis of spontaneous bacterial peritonitis, including bacterial overgrowth, decreased motility, structural intestinal damage, and decreased host defense mechanisms that normally function to eliminate microorganisms. Bacterial overgrowth in the face of decreased motility and increased gut wall permeability, secondary to structural damage, facilitates subsequent systemic infection. Reduced opsonic activity and phagocytosis allow the microorganisms to escape the host's defenses and subsequently infect the ascitic fluid. Spontaneous bacterial peritonitis with underlying cirrhosis was previously associated with a greater than 90% mortality rate, but with the advances in antibacterial therapy the rate has been reduced to approximately 30% to 40%. Gram-negative pathogens are associated with increased mortality compared with gram-positive pathogens. Early diagnosis and effective antibacterial treatment of spontaneous bacterial peritonitis are associated with reduced rates of mortality. Patient characteristics associated with increased mortality include renal insufficiency, hypothermia, hyperbilirubinemia, and hypoalbuminemia. To decrease the rate of renal dysfunction associated with spontaneous bacterial peritonitis, intravenous albumin at 1.5 grams per kilogram within 6 hours of diagnosis and 1 gram per kilogram on day 3 may be administered. Albumin acts as a volume expander to lessen hemodynamic changes, thereby preserving renal function. Albumin is recommended in patients with a serum creatinine greater than 1 mg per deciliter, blood urea nitrogen greater than 30 mg per deciliter, or total bilirubin greater than 4 mg per deciliter. The next question reads, pending ascitic fluid culture results, what empiric antimicrobial therapy should be recommended for M.O.W.? What is an appropriate duration of therapy, and how should the response to therapy be monitored? Although a positive gram stain and culture guides antibacterial therapy, nearly 60% of patients with signs and symptoms of spontaneous bacterial peritonitis have negative cultures. Initial antibacterial therapy for patients with a diagnosis of spontaneous bacterial peritonitis is typically empiric and targeted toward the most likely pathogens as described previously. Ampicillin plus an aminoglycoside was the traditional choice for empiric therapy. However, third-generation cephalosporins, such as cefotaxime and ceftriaxone, represent safer, more effective options. A fluoroquinolone may be considered an alternative in patients with beta-lactam allergies. Levofloxacin and moxifloxacin are preferred over ciprofloxacin, because of their superior activity against Streptococcus pneumoniae, the most commonly isolated gram-positive bacterial pathogen. Although parenteral therapy is preferred, oral fluoroquinolones may be as effective in patients with uncomplicated spontaneous bacterial peritonitis. As described earlier, aminoglycosides are not recommended in cirrhotic spontaneous bacterial peritonitis therapy because of the risk of nephrotoxicity, and the decision whether or not to use fluoroquinolones should be based on institutional antibiogram reports. Antibiotic therapy is recommended until the PMN count from the ascitic fluid falls below 250 cells per microliter, which normally occurs within 5 days. Franca and colleagues concluded that a 5-day course of sfotaxime for the treatment of spontaneous bacterial peritonitis was as effective as a 10-day course. M.O.W. should receive empiric therapy with an antimicrobial agent effective against Escherichia coli and other common pathogens such as Klebsiella species and Streptococcus pneumoniae. Any of the above-mentioned options would be reasonable empiric choices. The next question reads, after treatment is completed, should prophylactic antimicrobial therapy be initiated in M.O.W.? Recurrence rates for spontaneous bacterial peritonitis are high. Cirrhotic patients who survive an episode of spontaneous bacterial peritonitis have a 1-year recurrence rate of nearly 70%. Antibiotic prophylaxis should be administered to the following patients since they are considered high risk for the development of spontaneous bacterial peritonitis. Patients who have had 1 or more episodes of spontaneous bacterial peritonitis. Cirrhotic patients with gastrointestinal bleeding, cirrhotic patients with ascites, who have impaired renal or liver function, or cirrhotic patients with a low ascitic protein, that is 2.5 mg per deciliter. Antibiotic prophylaxis in cirrhotic patients is typically initiated to provide selective decontamination of the GI tract. The goal of this therapy is to reduce the burden of bacteria and subsequently prevent bacterial translocation and infection. Prospective, randomized studies in cirrhotic subjects with ascites support the use of oral antibacterial agents to reduce the rate of recurrence. The agents studied include oral norfloxacin, ciprofloxacin, and trimethoprim sulfamethoxazole. Rifaximin, a non-absorbable derivative of rifamycin, has also been shown to significantly reduce the occurrence of spontaneous bacterial peritonitis. Long-term prophylaxis is recommended based on the significant reduction in rates of recurrence in clinical trials. Long-term prophylaxis in patients with low ascitic protein, elevated bilirubin, or both may also be beneficial, but it has not been associated with decreased overall infection or mortality and, therefore, is not uniformly recommended. Clinical trials have provided evidence to support the use of short-course therapy, that is 7 days, of norfloxacin, no longer available in the United States, or ceftriaxone in cirrhotic patients presenting with GEI hemorrhage. Prophylactic therapy prevents bacterial infection and reduces the risk of rebleeding. Several cost analyses have been performed demonstrating that prophylactic therapy in high-risk groups of cirrhotic patients is cost-effective. Because rates of fluoroquinolone-resistant and trimethoprim sulfamethoxazole-resistant organisms are more prevalent in patients who receive long-term prophylactic therapy, its long-term use must be considered when initiating antibacterial therapy for the treatment of new infections in this patient population. M.O.W. has cirrhosis, a previous episode of spontaneous bacterial peritonitis, and a high total bilirubin, thus, he is at high risk for recurrence. Prophylactic antimicrobial therapy should be considered and may be a cost-effective measure. M.O.W. would benefit from ciprofloxacin 500 mg orally daily. The use of trimethoprim sulfamethoxazole would depend on local resistance patterns. The next question reads, HAM, a 33-year-old woman with HIV and end-stage renal disease, has undergone continuous ambulatory peritoneal dialysis, abbreviated as CAPD, daily for the past year. She presents with abdominal pain and a cloudy dialysate fluid. HAM has negligible residual urine output. What are the most common causative organisms related to CAPD-associated peritonitis? What empiric antimicrobial therapy should be initiated? How should antimicrobial agents be administered? Following spontaneous bacterial peritonitis, peritoneal dialysis is another cause of primary peritonitis. An estimated 45% of patients undergoing CAPD will experience at least one episode of peritonitis in the first 6 months of dialysis. Approximately 60% to 70% of patients exhibit peritonitis during the first year of dialysis, and recurrent infection occurs in 20% to 30% of patients. CAPD-associated peritonitis is theorized to originate from contamination of the catheter by organisms of the normal skin flora, contamination of the peritoneum from an exit site or subcutaneous tunnel infection, contamination of the dialysate fluid, or bacterial translocation. Alterations in host defenses of the peritoneum may also have a role in the development of CAPD-associated peritonitis. Clinical manifestations of CAPD-associated peritonitis include abdominal pain and tenderness, which is observed in 60% to 80% of patients. Nausea and vomiting occur in approximately 30% of patients, whereas 10% will have diarrhea and 10% to 20% will present with fever. The diagnosis of peritonitis is made on the basis of clinical signs and symptoms along with examination of the dialysate fluid for cell counts, gram stain, and culture. Characteristically, the dialysate fluid will be cloudy and have a WBC count greater than 100 cells per microliter with a neutrophilic predominance, at least 50%. The gram stain may be negative in 5% to 10% of cases, and blood cultures are typically negative. In most cases, peritonitis is commonly caused by a single organism. Regarding etiology, the most common causative organisms are gram-positive bacteria, accounting for 60% to 80% of isolates. Coagulase-negative Staphylococcus species, that is Staphylococcus epidermidis, are the most common causative organisms, followed by Staphylococcus aureus and Streptococcus species. Gram-negative bacilli are isolated in approximately 15% to 30% of cases, with Escherichia coli being the most common. Other common gram-negative organisms include Klebsiella species, Enterobacter species, Proteus species, and Pseudomonas aeruginosa. Anaerobes, fungi, and mycobacteria constitute the less commonly encountered pathogens. Next we will discuss antimicrobial therapy. In general, empiric antibiotic therapy should be directed against the most common causative organisms, both gram-positive and gram-negative, until cultures of peritoneal fluid are available. Intraperitoneal, abbreviated as IP, delivery of antibacterial agents is the preferred route of administration for the treatment of CAPD-associated peritonitis. The IP route provides very high local concentrations of antibacterial agents as well as the ability to avoid a venipuncture and allow the patient to self-administer therapy at home. Empiric IP administration of antibiotics should be administered when CAPD-associated peritonitis is suspected. When culture and susceptibility results are available, antibacterial therapy should be adjusted as necessary. With appropriate therapy, a clinical response should be expected within the first 48 hours. Treatment guidelines for CAPD-associated peritonitis provide a systematic approach for antimicrobial selection, dosing guidelines, and duration of therapy. Initial IP therapy recommendations include vancomycin or a first-generation cephalosporin for gram-positive coverage plus an antibacterial agent with anti-pseudomonal coverage. Because of the increasing rates of MRSA and methicillin-resistant Staphylococcus epidermidis, vancomycin may be the most appropriate initial therapy for gram-positive organisms, although cefazolin remains effective in certain geographical areas. Gram-negative therapy options include ceftazidime, cefepime, piperacillin tazobactam, or carbapenem. For patients who are intolerant of beta-lactams, aztreonam may be considered as an alternative agent for gram-negative coverage. Fluoroquinolones represent an option for CAPD-associated peritonitis given the extent of distribution into the peritoneal cavity. However, oral therapy should not be used in severe cases of peritonitis. The increasing prevalence of fluoroquinolone-resistant gram-negative Escherichia coli, however, is decreasing the utility of these agents. Refractory peritonitis, presence of cloudy effluent after 5 days of IP therapy, may require removal of the catheter, suggesting an exit site or tunnel infection. Oral antibiotic therapy, or intravenous therapy if severe, may be required for cases involving Staphylococcus aureus or Pseudomonas aeruginosa. When Staphylococcus aureus is isolated, the infection usually necessitates the removal of the dialysis catheter. Vancomycin is recommended for MRSA, with or without rifampin, for 1 week, although monotherapy with vancomycin is adequate, particularly if the infected catheter is removed. Conversely, cefazolin alone is adequate for MSSA. Coagulase-negative Staphylococcus species do not require prompt catheter removal as they typically respond well to antimicrobial therapy. Methicillin resistance is common for Staphylococcus epidermidis, thus, vancomycin is normally used. Enterococcus species or Streptococcus species should be treated with ampicillin if susceptible. Vancomycin should be used for ampicillin-resistant Enterococcus. However, VRE require treatment with linezolid, quinupristin dalfopristin, or daptomycin. In the case of culture-negative peritonitis and clinical improvement after 3 days of empiric coverage, a single agent directed toward gram-positive organisms may be continued for a total of 2 weeks. When a single gram-negative organism is cultured, e.g., Escherichia coli, Klebsiella species, or Proteus species, therapy can be narrowed based on susceptibility. Isolation of Pseudomonas aeruginosa most often indicates a severe infection, which may also involve the dialysis catheter. Therapy options include an anti-pseudomonal beta-lactam such as ceftazidime, cefepime, or piperacillin tazobactam with or without a fluoroquinolone or an aminoglycoside. In general, the beta-lactam antimicrobials achieve peritoneal fluid concentrations exceeding typical minimum inhibitory concentrations for most commonly encountered facultative gram-negative and anaerobic bacteria. Aztreonam can be used in the case of severe immunoglobulin E, abbreviated as IgE, mediated penicillin allergy. Polymicrobial peritonitis is uncommon and may indicate a more complicated intra-abdominal process. An example of an appropriate regimen for HAM may include vancomycin plus cefepime or an aminoglycoside given intraperitoneally. The clinician should monitor culture and sensitivity results to adjust therapy based on guidelines, local sensitivity patterns, and therapeutic response. The next question reads, 2 years later, HAM presents with abdominal pain and cloudy dialysate fluid. Candida albicans is cultured from the dialysate fluid. No other organisms are present. So my question to you is, how should HAM be treated? Fungal peritonitis is a rare complication of CAPD that is associated with significant morbidity and mortality. The rate of mortality in fungal peritonitis is approximately 25%. Considering the high rate of failure of therapy, CAPD patients with fungal peritonitis should have their catheters removed. Patients who have received prolonged or multiple courses of antibiotics, are on immunosuppressant therapy for a malignancy, transplant, or inflammatory disease, or have a postoperative or recurrent intra-abdominal infection are at increased risk for fungal peritonitis and should be treated with antibiotics. Most cases are caused by Candida species, most commonly Candida albicans. However, an increase in infection attributable to non-albicans species has emerged in many areas. Empiric antifungal therapy should be broad and include most Candida species. Echinocandins such as caspofungin, micafungin, or anisula fungin are the empiric drugs of choice. Amphotericin B may be administered intravenously IV, or IP, but when given IP, conventional amphotericin B is very irritating to the peritoneum. The azole antifungal agents can be administered orally IV, or IP. Fluconazole is active against Candida albicans, but it has dose-dependent activity against certain types of non-albicans species, such as Candida glabrata. In general, fluconazole is the drug of choice for Candida albicans. However, other options, such as apollyon or echinocandin, may be needed for azole-resistant Candida species. Therapy should continue for a minimum of 2 weeks after catheter removal, and the total duration may be based on severity and clinical response. HAM's treatment should include temporary catheter removal and administration of antifungal agents. Antifungal therapy with oral fluconazole 400 mg daily should be continued for at least 14 days. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 252.